during it was the Hurricane Laura deployment that we had. There was the day before, there was a call for there was a family of like 4 or 5, the mom, dad, all the kids had to be like, I think the dad drug out his entire family out of the house because everybody started getting real sleepy, and they all had the carbon monoxide poisoning. And so that was the first time I'd ever seen it. And like I obviously like I learned about it in EMT school, but it felt like one of those foreign things that we'll never see of like organophosphate poisoning. Like you
Right.
may see it once. And so being able to like be there and see how the medics were working, understand why it's dangerous. And then my partner after explained like, it'll present as XYZ, even though, they have the 100% O2 sat, they're still doing trash. Um,
Right.
so the next night we had this guy, he was he was there for like the demolition or reconstruction, whatever it was, sleeping in his giant, what's it called? One of those big, not tractor things, but like the things you see doing road
Right.
work on the side of the road.
Okay.
Not a crane. I don't know what it is.
Fair enough.
I
But
just
yeah,
know it blocks
yeah,
traffic.
some kind of giant piece of equipment, right?
So
Yeah.
like he would sleep in the cab, and he called because he was, I don't think he was tired. He just felt like he couldn't breathe. And so we get there, and like everything was fine. Everything was completely fine. And he was like, yeah, I want to go to the hospital. I want to get checked out. And so we dropped him off. And I told my partner, like, was that the thing? Or it's really convenient that he just wanted to be off work for a day. Turns out his CO2 levels were trash. He
No.
he started decompensating, I think like that night. So
Yeah.
now every time we go to a call, I wish I was joking, like shortness of breath or altered mental status, there's that small part of me that's like, oh God, this is it again. I can't miss this.
It's so funny how stuff like that like will stick with you, though, right? Like especially like I think that's a thing for me as well as I learn more from my mistakes than I do from like my successes, right? Because if I run a call and everything goes well, I was like that's like easy day, right? Easy day. Don't have to think about that anymore. But if I mess up, I'm gonna think about it for weeks, like years. I'm still there are things that like I'm still thinking about like to this day, right? There are during my clearance as a paramedic, I brought a like very easy seizure call, and like it had happened like a couple times, blah blah blah. And my preceptor like knew I was messing up and like didn't. It was one of those like let them drown type situations, right? The doctor like absolutely tore me apart. I think it was I didn't get like how long the seizure lasted, the initial one, and I didn't get like how long it was in between like subsequent seizures or and how many he had had total. Like I had not gotten like the amount of information that I should have, and like the doctor was like asking me questions, and then he did the thing where he was like asking me like more questions like faster and faster, and he was like, you clearly don't know anything about this patient, and like walked away and just started talking to the patient instead. And it was like a very embarrassing moment, and I was initially upset, not the way I would choose to teach somebody, but for me, it stuck. It stuck because I will ask people like all of the questions now all the time. So it's weird how things will stick that way. Yeah, I see you grimacing. It was a very embarrassing moment for me. Thank you for letting me be with that.
I think that also deals with in our field with our schooling and stuff like that. Like we're trained as we should be to be like the person on scene and the person on that call that knows even though we may not feel like it may not be accurate. Like, we know what to do. We know the assessment. We know, like you said, like the questions to ask. Where this sounds so prestigious and dumb, but like, we're the person that people turn to when they don't know what else to do.
Right. Okay.
And to have those moments where like our humility and pride is checked, it
Yeah.
hurts. It hurts so bad.
It does. It does. There's a so there's a saying going around in the tactical communities or whatnot. It came from a prior team guy, but it's the simple like thing of be a pro, right? And that's, I think it applies to EMS and really really well. Is that we should be like we are professionals, like, so it's our job to be a pro, and that doesn't matter the time of day, it doesn't matter what kind of day you've had, what kind of calls you've had prior to this. When you show up and you step out of that ambulance, like, it's your job to be the person that they're expecting to see, right? And I think that can weigh very very heavily on us, but it's something that we have to do. It's why I don't social. You'll hear me, or you'll see me. You won't hear me as much, but you'll see me talking about like fitness for providers and stuff like that. And it's all part of it, because like you said, even though it is a little like played out or whatever, like, these are people that are having a terrible terrible day that have called us, and they are expecting a certain level of performance once they get there, right? And if you are that type of person, whether find like the type A personalities or whatever else, and I would assume that if you're listening to an EMS podcast, then you probably do care enough about your career to like want to be that person. Yeah, be a pro, and those things are going to weigh heavy on you when you mess up. Like, it's just the way it is. We try to tell people not to beat themselves up over it. Like, when things go wrong, like, it happens. It happens to all of us, no matter how much experience you have. Uh, Learn from it and just move along, right? But we do, and we beat ourselves up over that stuff.
I'm thinking of this one time, and it still hurts. It was like my first clinical ride time in paramedic school. Before that, obviously, I was the EMT. I think I'd worked with somebody else on one cardiac arrest ever. So I'm still like in the beginning steps of paramedic school.
Right.
Pretty much zero experience in that type of call. So we get a cardiac arrest for a nursing home. We get there. The medic's kind of leading most of it, because I'm like a deer in the headlights pretty much. And he hands me the Epi 1 to 10 pre-fill with the little vial syringe that you just twist it in. That's it. I had no clue how to set it up. I literally started like reaching for a 10 mil syringe, a needle, and we're in the cusp of this cardiac arrest. And he turns around and he's like, "What are you doing?" And I'm like, drawing it up. I'm like, I don't know.
I don't know. I hope it's good.
So after that, bless his heart, he was not a good preceptor.
Right.
I literally like, I went through our bag and I looked at every single vial, every single syringe, every single cap. And I'm like, I can't mess this up again. This was rough. And like now on every code, I'm like setting it up and I'm like, whoa, never again.
Right.
That little fear is still in my heart.
And that's the it's like we talked about before too, just like you, like as an FTO or as a preceptor or instructor, whatever, terminology you use, like you need to know the capabilities of your students, right? You and the same goes for your partners, like paramedics. If y'all don't realize it yet, like you may not be an FTO, you may not be a preceptor. You're with this person for 12 hours. And if this is like your regular partner, like if you work in a service where you have the same person day in and day out, it behooves you to like teach that person, right? And if you aren't capable of doing that, then like you can't be mad when you're messing stuff up because like who else are they going to learn it from? Like they're not going to go to another medic, and if they do, I mean, get on them, right? But like we need to all be able to like be instructors at some point, right? And even with little stuff like that, like you clearly fixed it and it stuck with you. That speaks so highly to like the amount of like processing power that gets lost during those like chaotic events and stuff like that. So if you have not talked to your partner, if you have not like if they don't know what to do, if this is your first day on the truck with somebody who's obviously a fresh EMT, um, you can't be mad about that. Like this maybe we don't know. You don't know where these people come from. A lot of agencies get people that are like very, very young or fresh out of high school, or I had high school students riding with me at one point in time. Like they may have never like seen somebody in cardiac arrest or something like that before, seen somebody who was very, very sick before. All of that stuff that has to be taken into account. Yeah, whether you're an FTO or not, like it behooves you to really, really like take a look at all those things and try to teach them the best way that you can.
For me, it wasn't just like teaching the little aspects of like my first partner, our first shift together, how to put the little saline lock on the flush
Mm-hmm.
and then flush it out. So that way there's not the giant pulmonary embolism awaiting the patient.
Right.
And like how to set up spike bags and stuff like that. I think another part of the teaching aspect is understanding when something does go wrong, how that person will be receptive to criticism or instruction.
Yes.
And my first partner had this, I don't want to say painful way, but he had this way of letting you come to the conclusion that you screwed up on your own. And most of the time he would start with like a story of, yeah, one time I had this one partner, XYZ, whatever. And then you'd hear it and you'd be like, man, that's crazy. But then he'd be like, well, look at us now. And so like the one time I specifically remember, I was trying to bring us to the hospital with this nursing home patient who possibly had a head injury. I was working in the rural setting and we were going to Lafayette General Hospital. So I brought us through downtown Lafayette and he comes up to the window. He's like, bro, where are we? And I'm like, I'm following GPS. I don't know. So we get to the call. Nothing detrimental happened, nothing crazy. But we get back in the truck and I'm embarrassed because to this day, I'm still very geographically challenged to this day. And I'm working on it. I'm trying. It's just a struggle buzz. So we get back in the truck. He doesn't say anything for like 10 minutes. And I just like felt it, like that tension. And all he says is he's like, there was one time I had this one partner who didn't check the O2 during our morning shift. He started getting lazy and he didn't check the O2. And he was like, you know what I needed on a shortness of breath call? He said, I needed O2. He's like, it's the one thing my partner could have done out of all the things besides what I can do as the paramedic. He's like, it's the one thing I needed and I didn't have it. And then he said, Alexis, what can I do for a head injury? And I'm like, bro, I don't know your meds. I don't know what stop the bleeding. I don't know. He's like, no, for a head injury patient, I need to bring them to the hospital to get a CT scan as soon as possible. And he's like, when we're driving, what is your job? I'm like, to get us to the hospital on critical calls. He's like, correct. That's the most important thing you could have done for me in that call. He's like, what did we not do? I said, get to the hospital as soon as we can. It's not that like he was trying to be mean, but like to this day, I'll never forget one, check the O2, but
Yeah.
also like that ability to not say you're disappointed, but bring up something that's like, hey, we need to do better.
Do you find that effective or?
For me, it was.
Yeah.
And there were so many other times he'd be like, I had this one partner. Whenever he would start it off, I knew what was coming and I would already be upset with myself. But it was, like I said, like it was never a berating thing. And I don't know, he had that very dad-esque essence to himself. So it's kind of like my dad was fussing at me, but more of, and like you said one time, not so much that I can feel like an idiot, but more of, hey, here's this moment, here's a teaching experience, and here's how we're going to be better from this.
Right. Right.
I'll never forget that moment, man. It still hurts.
I like the so I normally go with the like crap sandwich approach to coaching, it's how I was taught, and it works. It works for me anyway. It's the you talk about like something that went very, very well, right? And then you talk about like what went wrong, and then you finish up with something that like also went well. So you got to kind of like build that sandwich with just the crap in the middle and compliments on both sides, so you're not absolutely destroying somebody's confidence in things. Like that's I don't know. There's like I said earlier, there's different ways to coach everybody.
Yeah. One thing I try to teach, which I don't teach a lot, I don't think I'm equipped to, but like my friends that are going through EMT school or people that are going through paramedic school and they start doing the ride times. One thing that I picked up from whenever I was teaching, when like I started student teaching and stuff like that, was to get criticism, to get effective criticism that's going to make an impact. You ask, what went well? What could have gone better? And next time try. And I use that a lot, especially for paramedic school after these calls. That way, like I can kind of consistently see like what I'm doing good at, or something that I don't need to necessarily harp on, the things that I need to improve on. And then that little tidbit of advice and direction of like, from here on out, stop screwing this up.
Right. And I would say I still do that, right? For myself and for like other people. If I work a critical call, I'll normally, I'm a firm believer in like after action reports or after action reviews. And your typical AAR has the same thing, just worded differently. We do sustains and improves, right? So when after the same thing, you're asking the same thing, like what went well and what should we keep doing, and then what can we do better, right? And that's kind of also what can we take away from this? How can we improve? And I do that like to this day as a provider. If I'm on a call and like I'm working with somebody, a lot of times now at the agency I work with, especially being PRN, when I'm filling in shifts and stuff like that, there's a lot of times where I'll end up being double stacked, and I find being double stacked can be both a blessing and a curse, right? Because like it depends on who you're working with a lot of times, and there can also like depending on the person, like you'll get kind of a too many chiefs thing. Like that's what, and there's like little stuff too that we realize that we don't remember to do anymore. Somebody normally does it for us, like restocking and stuff like that, and checking the oxygen. A lot of times, like we have to make a conscious effort to remember to do those things. But after action reviews, like are huge, right? Like anybody that's like gonna seek any kind of improvement, I would encourage them to do that on like any call. The same as like you can do it on anything. You can do it on your transfer. Like, hey, what went well? What can we do better? Like how do I like how do I like be the best that I can be at taking this person like from their house to the dialysis center, right? Like how can I do that better? Um, it's a good practice. It just you know shows that you care about your performance like as a provider and everything else.
I want to throw this in there.
Mm-hmm.
Um, I've only ever worked for private EMS agencies, which entails having transfers and stuff like that. As an EMT, and still to this day, I don't mind transfers because it's helped me adapt to like how to have that small talk with people. And even as far as like asking medical history, like asking, what's your medical history? Oh, you had a stroke. When did you have that stroke? What kind of deficits do you have now? XYZ. My favorite, honestly, is these elderly patients who, like, one, they're full of sass. 9 times out of
Mm-hmm.
10, they have such an attitude, and not in like a mean way, but like they don't give a rip. They're going to say whatever they want. And then it's like asking that life advice. And especially if they're married, what's the secret to a good marriage? 9 times out of 10, it's keep your mouth shut. I don't mind. And then honestly, like yesterday, if it's a shift where we're getting it handed to us, you have that one where, like, even though your patient may be sick, you're not having to show up at their house from like a baseline, whatever. They're pretty stable as is. And you
Right.
just got to bring them point one to point two. And then
Mm-hmm.
I wouldn't recommend this, but it's a shame if it takes just a minute to get the patient to your stretcher. It takes a minute to get them to the destination. It takes a minute to, get them set up at the destination hospital. And then you got to maneuver all the way back to the ambulance.
Right.
Not that I do that. That's wrong. Don't do
It's
that.
it happens in busy services no matter where you are, I think. But um and it just depends on it's a whole different topic really. But like so I know like where I work, we have 3 trucks to cover an entire area or whatnot. So for us, we have to be really cognizant of like what the other trucks are doing. And if there are like people available because we don't have the same type of dispatch, right? We just have a 911 dispatch center that sends that like everything's over the radio. We don't have CAD systems or anything. So like uh, if you're not a little bit aware of what's going on, like you'll hear like there are calls holding, and same as anyone else, same as you. There are times when I absolutely want to like stand back a little bit and like come on, like I just I need like 30 seconds to catch my breath here. Uh, but you also know that like there's nobody else available at that point, right? So you
Yeah.
gotta get back out there and do it a little bit. So I know I definitely know where you're coming from with that one because I've been in the same spot, but like I think when it's time to work, we all will also just like kind of go about it. It made me think of one of my other like tips for paramedics as far as like dealing with their partners and whatnot, especially new employees. Was and most of those are from things that I did really poorly at one point in time that I've learned to do differently over time, and that's like groaning when calls come out and stuff like that. Because I know as an EMT, and then like further as a medic, when I'm getting new EMTs and everything else, they're already disappointed about what the job turned out to be. Right. This is not what they expected most of the time. For the students out there, if you don't know, it's not all flashy all the time, although it can be. Um, but they don't need your negativity on top of that, right? So like
Right.
that just goes back to like being a professional as much as possible. It's almost like we're at work as professionals and we're expected to maintain a certain level of it seems like it's forgotten every once in a while.
Being a professional is hard sometimes.
It absolutely is.
Was there anything else you wanted to bring up or cover or anything like that?
Do you have any like go-to apps that you use while you're at work?
Number one, Google Translate.
Google Translate's huge, yeah.
Yeah, I learned very quickly in Utah, and especially coming back to Louisiana. Some people literally only speak Spanish. I don't know how they survive in, an English majority country, but they do somehow. And then shame on me that, sorry, Professor Sanchez, I don't remember a lick from my 2 years of Spanish in college.
No,
So I know like leche is milk, but that doesn't help me.
probably not gonna be the important one.
So I use Google Translate. I'm actually going to go ahead and go through my little work folder. Full Code Pro for your cardiac arrest, because if you don't have somebody to actually write down times and notes and stuff, what are you going to do? Just guess. You can't do that.
Use the event button on the monitor.
I mean that too, but like I'm kind of handling up on a couple of stuff. I'm not saying I'm babysitting some of the volunteer firefighters. And then my partner's like tied up and stuff. It's like I just have this app right next to me. And like we get there, start CPR button. As soon as I push the little thing, and it's like right at my knee. So it's just right there. So I'm like pushing the epi. I'm like, boop.
I use Code Runner for that.
I mean, yeah.
Yeah, I'm sure it's the same thing.
Probably. What else? I mean, obviously our protocol app, just because sometimes on the way to calls, I'm like, I think it sounds like this. What is that thing? I don't know. They have the critical app, which I'm about to go back through it for what it was. I haven't
Critical app
is
is
trash.
Very, very good. It's got a lot of calculators in it, and it's very easy to find trip rates and stuff like that quickly.
Yeah, it's.
I
haven't opened it in a minute, but it's good.
Big fan of the critical app.
I know they have the Hand Heavy app. I personally don't have it, but I've seen it. It is incredible.
Yeah. Yeah, we don't use the system itself, but it's a very good app.
Another one I've used at least twice since I've been back in Louisiana is PD Stat. It's like you open it. Yeah. You know which one it is?
Yeah.
I gotta have it because I know how to do my job. Obviously, I'm pretty decent at it. I haven't killed anybody yet that I know of. Follow up is hard to get.
Right.
But like,
man, I don't know that pain. I did follow up on almost everybody.
I try, but also
it's worked into our reporting system. We get we get outcomes from everybody.
Must be nice.
It is.
Like, I mean, if we drop off at that hospital later, like last night, we dropped off a patient earlier into the shift. We dropped off at the same hospital later. I look at the board, the patient's still there. I go to the doctor. I'm like, hey, what do you guys think? What have y'all done? What's going to be like the outcome? And sometimes they'll be like, oh yeah, like last night they were like, it's early onset heart failure. And I was so amped about it in that moment because I was 99.9% sure it was. I look at the doctor, I'm like, yeah, called it. But I don't know. I don't, especially PD stat. Pediatric dosages, it's a lot.
Yeah. Well, it's that ties back into the like cognitive offloading stuff, right? So like the less I have to think about in the moment, like the better I can perform in that moment. So like I'm not gonna remember PD doses for every weight class. So like I may as well just look it up. I did the same thing. I still do the same thing a lot of times with protocols. Like I'll look up a protocol just to make sure I'm not like messing up, because like that cognitive power is not, it's not all there, and I can't remember every single thing. Like, so if I have to check something, I check something. It's no big deal there. One other one that I use that uh, I found really, really useful was Hippocrates. It Hippocrates, you can look up like meds and med doses. Um, so like when the patient hands you that giant Walmart bag full of pill bottles, if there's things in there that like you're like, oh, I don't know what this is, like type it into Hippocrates. It'll tell you what it is, what it's for, and what their dose should be. Um, Along with that, you can also use it to identify like pills and tablets and capsules. So I normally recommend it for law enforcement for when they're finding like random stuff in vehicles and whatnot. Yeah, Hippocrates is probably the only one that you like didn't mention that I used. That and up to date, but you have to have a login for up to date. But all up to date is basically like medical wiki, except it's accurate. So like WebMD, but good, right?
But
Like,
good.
yeah. And it's literally updated like daily. So it's got like the most current information from evidence-based practices within it.
Nice.
Um, that was the only big question I think I had
I
for
like
you.
the Hippocrates because I'm
I
gonna
use
be
it on.
honest. Like I know some meds, but then I look at some of them and like it's the trade name. And I'm like, I
Yeah,
don't know what this is. I'm still gonna put it in my report, but like I don't know what this is.
yeah, it's very it's really good. I mean, at this point, I think I know a lot of the like commonly seen ones. You get used to, like you get used to your area. You know what people are normally prescribed. Like they're most of the time, like there aren't doctors that are prescribing like off the wall meds for people. But if there's something you're not familiar with, like it's there. Just like pop it and look it up if you have the time.
Um, it's not an app, but one thing I've done, I have like this teeny tiny little notebook that I keep in my pants pocket at work,
Mhm.
and it's all of our medications that we carry, A through not Z,
Yeah.
probably T for TXA, but but it's like every medication, the protocol for what it's for, and then dosages. And
Right.
sometimes on the way to calls, especially honestly for pediatrics, if it's like a seizure or something like that, I look up that medication and then I get my teeny tiny little notebook I write notes on calls, and I
Mhm.
write down like the dose per kilogram or whatever it is. So that way when I get there, all I have to do is literally ask like, how much does baby weigh? And then
Right.
I mean I have to do the math of divided by 2.2, but still.
You just do the so I just learned this recently, and I feel bad that it took me 4 years or so to learn it. But you can just do the thing where you like divide by two and then subtract the first number, right? Um, so like 180 becomes 90 becomes 81 kilograms. But
I'm
yeah,
humble enough to
super quick.
say math is really hard. I literally, one time I made a B in, I forgot what math class in high school, and I cried because I was so proud of myself. I do not math well.
No.
So I'd be whipping out my phone with that calculator so fast.
Yeah, absolutely, absolutely. No, I do the same thing. I have a notebook that I keep like in my pocket at work for little notes. Either that or I take I'll put tape on my legs and I'll write it like if I was doing especially doing CCT, if I was like sitting and had to write down lead trip rates or vent settings or something like that, I would just take the wide like painter's tape or the like ribbon tape or whatever it was, and put it on my leg and just start writing there. I don't like writing on gloves because I throw them away all the time. I change gloves
Exactly.
too. Yeah, so I don't write things on gloves. Um, I'll either write it on a sheet or in a notebook if I remember to put my notebook in my pocket that day.
And disclaimer, there's never patient information on the
No,
notebook. Just, I get scared I'm going to lose it on a call and somebody's going to open it. And then I get my license taken away because HIPAA,
right.
Big Papa HIPAA. Um, Anything else you want to add or?
Um, no, we could sit here and talk about like how to be all the ways that we've learned to be better providers by doing things the wrong way for a long time. Um, that's it. That's it. All I've got for right now. You know, if you have any questions, or if you just want to chat, or if you think I said something that was like really, really dumb and you just want to berate me about it, like again, I'm you can find me at nomadic clinician or nomadic.clinician on Instagram and Facebook. And yeah, just send me messages. They're not it's a public page, so you can just shoot me messages, tell me how dumb I am or whatever else. Um, or just reach out. That's it. That's all I got.
20 out of 10 recommend reaching out. It's pretty, I'm not just saying this because you're here, pretty incredible stuff. I've learned a lot. I mean, by no means do I have not arrived. I don't know a lot, but it's good stuff. Whether, like we kind of talked about, whether you're in EMS, whether you're not, something that everybody can gain information from, experience. And overall, as we all know, how to be better. So, Mr. Josh, that's all you got. That's all I got. And as I wrap up every single episode, so with that,
the 22 at the Lips podcast is designed to support, not replace, the relationship that exists between a practitioner and his or her medical director. The views and opinions expressed in this podcast are those of the host, guest, and not necessarily of Master Medics. The information provided during this podcast is intended for educational and informational purposes only. It is not a substitute for your approved protocols.